My name is Heun, I'm a consultant psychiatrist, and I wanted to talk to you about ADHD. ADHD is getting more and more recognized, and one would have to say that this is initially a child disorder, but you meet more and more people who think or who have developed symptoms in their middle age or even when they're older. So I recently had a patient who was 62 asking for a diagnosis of ADHD. Right, so what's ADHD? ADHD is Attention Deficit Hyperactivity Disorder, and there are three main symptoms. One is inattention, then is hyperactivity and impulsiveness. And the ADHD is quite heritable. That means, it runs in families. And if one family member has it, the chance for the other one to have it is 2 to 3 times higher. Usually it's common in people or children with low birth weight, in babies born to mother who take drugs, alcohol, tobacco during pregnancy, or having a head injury, or children who have genetic or other metabolic disorders. Sometimes it's difficult to distinguish from attachment disorders or people having learning disabilities, or sometimes anxiety disorders or side effects from medication or brain injury. There's lots of comorbidity, which means that people who have ADHD very often have, or children who have ADHD very often have other disorders, including specific learning problems, motor coordination problems, Asperger's or autism spectrum disorder, tic disorder, substance abuse, anxiety, depression, and bipolar disorder. So what are the clinical features? They're inattention, so people don't look at details, they fail to sustain attention, they're distracted, they fail to finish tasks, they can't organize themselves, they lose things, forget things, and sometimes avoid tasks which are demanding continuous attention. Then there's hyperactivity, there's fidgeting, playing with the hands, playing with the arms, not being able to sit still, and being always on the go. Then there's this impulsiveness, which is talking excessively, blurring out answers, not being able to wait their turn, or being interrupting others. There are other problems which are common in ADHD, which are sleep problems. People sometimes would profit from a sleeping course, so we sometimes have CBD courses who help with sleep, and when sleep can manage, sometimes the ADHD can be managed better. Sometimes people have low self-esteem, and as a result of the disorder, there can be some problems with family or peer relationships or relationship with friends. Sometimes they have a risk of accidents, and also there's some risk of poor performance. In the long term, there can be lots of depression and other comorbidity. Problems with work can lead to underachievement. There might be some antisocial personality problems, and some people may, and this is what I'm working in general adult psychiatry, we may see people who where the ADHD persists into adulthood, which is not too common, but it does happen. Sometimes the symptoms get much better when people get older. Right. Usually hyperactivity and impulsivity they wane easier than inattention. So usually there is sometimes dysfunction, and if people have a poor prognosis, then they might be having some social deprivation. There are parental problems, which might be cause or the consequence of the disorder. So, learning difficulties can make it worse. So what we have to do to find out, is you have to interview the family, see the child. The best is to see the child in different circumstances, and to get information from other parts. These are the parents and the school. This is also very helpful in people who are a bit older and suspect ADHD, because what happens is that these symptoms which we find in ADHD in these questionnaires are extremely common. So did you blurt out an answer one, or are you impatient? Many people have plenty of these symptoms, and they don't qualify for ADHD because the symptoms wasn't severe enough. But it would be helpful and is helpful to have information from others, from the school. And yes, rating scale will help, the Connors scale or the DIVA scale. They all give some indication, but they also lead very often to false positives. Looking for comorbidities important. Let's say that way, it's very, very difficult to, let's say in older people, to have a patient with schizophrenia or depression or anxiety or OCD who hasn't had ADHD symptoms. So that's very common to have that. Usually one look also for physical problems, because cognitive impairments might be covered up by ADHD. What's to be done? Psychoeducation, explaining what the diagnosis is about, what it makes. One can try medication for methylphenidate or others. What's also very helpful are behavioral interventions. So, encouraging that people have a reinforcement of the desired behavior and giving rewards. That might be something positive, from the family. It might be a tap on the shoulder or a friendly remark. I think, it's the other thing is being consistent in the family, just being positive about achievements, being positive, not being overcritical, and trying to reduce distraction. Trying to, if school tasks to be done or other working tasks to be done, to break it down into manageable steps. These are school interventions, and you treat certainly anxiety and depression, and some recommend fish oil or other dietary changes, which usually don't help that much. There are other organizations which usually can help and support, and sometimes the support and understanding is what patients are looking for. Right, so this is a mixture of looking at children and adults, and we come back to that and in a different or near future video. If you want to see more of these videos, you're very welcome. We produced quite a few, and I think they're all hearable on the radio when you drive to work. And I think if you really look at these videos, you can learn a bit. I hope you enjoy that, and you can also follow our channel, which provides some more academic stuff, which is about the archives of global psychiatry and the publications. Thanks for your interest, and have a nice day. Thank you. Bye.